Hello, everyone. We shall continue our series on organ donation. In the first module, we shared how organ donation can be life saving. In module 2, we addressed what is organ donation, types of organ donation, and the organs that can be donated by the living and the deceased. Within this module 3, we shall explore the concept of brain death certification, and the process of organ donation. Let me begin with a road traffic accident where a school bus collided with a car. Immediately, a crowd gathered and tried to save the life of the driver in the car. An ambulance was called to take the patient to the nearest hospital, and the injured driver was rushed to the casualty. The patient was immediately attended to by the doctors, and they tried their very best to save the injured driver. But the man succumbed to his injuries and was declared brain dead. The relatives were shocked to see the badly injured victim dead. What is brain death or brainstem death? It is the absence of all brainstem reflexes. Brain death is the irreversible end of all brain activities. This occurs due to a major head injury or bleeding in the brain due to a stroke. Brain dead persons are kept on ventilators to ensure organs remain oxygenated until they are harvested. India recognizes brain death as a legal form of death. The patient needs to be treated in the ICU to be certified as brain dead. What is brainstem? The brainstem is the distal part of the brain that is made up of the midbrain, pons, and medulla oblongata. The brainstem helps in regulating breathing, heart rate, sleeping, eating, movements of eyes, and recognition of pain stimuli. It also plays a role in conducting nerve impulses. The causes of brainstem death are trauma to the brain, intracerebral hemorrhage, ischemia to the brain, a tumor or a subdural hematoma, and a post resuscitation hypoxic insult can also lead to brainstem death. Drowning, gunshot injury to the head, carbon monoxide poisoning, drug overdose, and hanging can also lead to brainstem death. Let us look at the pathophysiology of the brainstem death. An injury to the brain causes severe damage of the neuronal tissue, leading to edema and increase in the intracranial pressure. The elevated intracranial pressure in turn reduces the cerebral perfusion pressure and the cerebral blood flow. A vicious cycle is established in which decreasing cerebral perfusion and increasing intracranial pressure reinforce one another until blood no longer enters the cranial cavity, and this leads to transtentorial herniation and coning at the foramen magnum. Coning causes compression of the lower brainstem. This herniation, where the brainstem gets crushed, can permanently damage the brainstem, leading to irreversible hypoxic ischemic brain injury and finally leads to brainstem death. The respiratory center is situated in the brainstem and hence the patient stops breathing. There are a few conditions where the patient can be unresponsive and hence could be confused with brain death, and they are shock, hypotension, hypothermia, patients who are on drugs like anesthetic agents, neuroparalytic drugs, methaqualone, barbiturates, benzodiazepines, amitriptyline, trichloroethylene, and conditions like brainstem encephalitis, Guillain-Barré syndrome, encephalopathy, severe hypophosphatemia, or alcohol intoxication. Hence, we need to ascertain if patient is actually brain dead. What is the difference between brainstem death and coma? In brainstem death, The brain stops working completely. The respiration stops. There is no movement. The patient does not respond to stimulation. It's a permanent and an irreversible state, and the body has to be maintained on a ventilator. Whereas in coma, the brain is functional and the respiration continues. Body movement and eye movement are present. The patient responds to stimulation, and it's a temporary and a reversible state where the patient can recover completely. The signs of brain death are irreversible loss of consciousness, absence of respiration or apnea, a flat EEG showing no brain activity, and loss of brainstem reflexes. How do we certify brain death? We find that the patient does not respond to pain, the cranial nerve reflexes are absent, that is, there is no pupillary response and the eyes are fixed, there are no corneal reflex, no response to calorie reflex test, no spontaneous respiration, no cough or gag reflex. In this slide, let's see what is calorie reflex test and how it is performed. Calorie reflex test or vestibular calorie stimulation is a test that involves irrigating cold or warm water into the external auditory canal. Normally, we see nystagmus of the eyes, that is, rapid movement of the eyes, whereas for a brain dead patient, nystagmus will be absent, and this suggests brainstem injury and confirms that the patient is brain dead. The apnea test is a mandatory examination for determining brain death because it provides an essential sign of definitive loss of brainstem function. Apnea test is a gold standard test to confirm brain death. A team of doctors conduct the apnea test. The procedure of apnea test is pre-oxygenate with 100% oxygen for 30 minutes. Connect a pulse oximeter to the patient and disconnect the ventilator. Deliver 100% oxygen at 8 liters per minute. Look closely for respiratory movements. Measure the PO2 and PCO2 and pH after 10 minutes and reconnect to the ventilator. If respiratory movements are absent and arterial PCO2 is 60 mm of mercury, the apnea test result is positive. That is, it supports the diagnosis of brain death. If during the test the systolic blood pressure becomes less than 90 mm of mercury, or the SpO2 drops below 91%, or the patient develops cardiac arrhythmias, immediately connect the patient to the ventilator. Lack of cerebral circulation is an important confirmatory test for brain death. The image on the screen is the angiogram of a normal patient on the left side, and on the right, you can see the image of a brain dead patient which shows no blood flow. Once the diagnosis of brain death is made, an individual is pronounced legally dead. This is the time that should appear on the death certificate. The time of death is not the time when the ventilator is removed. You may wonder if brain death is confirmed, why does an individual's heart continue beating? As long as the heart has oxygen, it can continue to work. The ventilator provides enough oxygen to keep the heart beating for several hours. Without this artificial help, the heart would stop beating. A panel of doctors are involved in certification of brainstem death. They are the doctor in charge of the hospital, a neurologist or a neurosurgeon, the treating doctor, and an ICU intensivist. What we need to realize is that organ viability decreases the longer a patient is brain dead. So, the longer it takes to certify brain death, the organs become hypoxic and can no longer be utilized. A study found that as the space between the first and second exams increased, the likelihood of a family refusing to donate organs increased. The longer it takes to declare a patient brain dead, the less likely the patient's organs would be donated. Let's look at the organ donation process flow. You identify a patient with Glasgow Coma scale less than 7. Then you inform the family regarding the poor prognosis. Then the first apnea test is done to certify brain death. The family is informed and counseled. Then the second apnea test is performed by another set of doctors after 6 hours. If the apnea test is positive, the patient is declared brain dead. The relatives are informed and supported and counseled. Once the reality sets in, we introduce the topic of organ donation and request for the eyes. This is because, in an Indian context, the family is more familiar with eye donation, and it is found that if the relative consents to donate the eyes, then the other organs can also be requested. Once the consent for organ donation is received, then the next phase of care is donor management, where steps are taken to ensure that the organs are well perfused in order to procure them for organ donation. Then the ZTCC, that is the Zonal Transplant Coordination Center, is informed. They coordinate the distribution of organs. This is a recap of the organ donation process in a pictorial format. The identification team identifies potential brain death victims and informs the counseling team. Parallelly, the brain death certifying team is informed. Once the patient is certified brain dead, then the donor management protocol is initiated in the ICU. The retrieval and the transplant group work alongside in performing the surgery and retrieving the organs, and then the treatment team continues care of the recipient. The absolute contraindications to organ donation include a donor who has septicemia or bacterial infection. If the donor has been hospitalized for more than 72 hours, a blood and urine culture are mandatory to rule out septicemia. The other contraindications are malignancy or cancer, active tuberculosis, all secondary intracerebral tumors, undiagnosed febrile illness, active viral infections like encephalitis and meningitis. The relative contraindications for organ donation are patients who are infected with HIV. They can donate to others who also are carriers to the virus. The recipient should be informed regarding the donation. Donor management involves optimizing the cardiopulmonary and endocrine systems to restore optimal circulating intravascular volume, normalizing electrolyte and metabolic imbalances, and maintaining the hemodynamics to promote adequate perfusion and oxygenation of donor organs, thus maximizing the viability and function of organs. Optimal donor management is essential in both the intensive care unit and in the operating room to maximize the function of transplanted organs and the quality of life and survival benefits conveyed to the recipients, thus maximizing the viability and function of procured organs. The management goals include maintaining the systolic blood pressure within 100 to 120 millimeters of mercury, mean arterial pressure more than 60 millimeters of mercury, central venous pressure 8 to 10 millimeters of mercury, hemoglobin 10 gram per deciliter, hematocrit 30, arterial blood gas pH 7.37 to 7.45, and PaO2 more than 80 mm of mercury, PaCO2 40 mm of mercury, SpO2 95%, urine output 1 to 2 ml per kg per hour, and a core normal body temperature, and to correct and maintain the glucose and electrolyte abnormalities. The general care for brain dead patients include hand hygiene, maintaining central line and arterial line, and monitoring them, nasogastric tube feeding, Foley's catheter, maintaining a propped up position, including frequent position changing, warming blankets to maintain the body temperature, prophylaxis for deep vein thrombosis, pneumatic compression devices, eye care including taping of the eyelids, tracheal toileting like frequent airway suctioning, including stress ulcer prophylaxis and broad spectrum antibiotics. So, to conclude this session, let's have a quick recap. In this session, we have seen what is brain death, the causes of brain death, the pathophysiology of brain death, the difference between brain stem death and coma, the signs of brain death, certifying brain death, how to perform the apnea test, and the panel of doctors involved in certifying brain death, the organ donation process, the contraindications to organ donation, and the donor management goal, and finally, the nursing care of brain dead patients. So, as nurses, let's recycle life and promote organ donation.